I'm Tom Haberman, and welcome to the Lymphoma E Tumor Board. Just as an update, we will be resubmitting the paper and the grant that we have to do other things with this. We're meeting with that sponsor tomorrow, and so we have some other things ongoing. So first case is that of an 82-year-old male who presented with lymphocytosis. On April 13th of 2012, he had a normal white count with differential. In 2018, on the outside, the white count was 14,900 with lymphocytosis. In February, he developed a forearm infection after an encounter with a cat. On February 15th, the white count was 42,400 with a platelet count of 125,000. On March 12th, flow cytometry was, quote, suspicious for prolymphocytic leukemia, unquote. On March 12th of 2020, the white count was 33,900. He was seen in the CLL clinic on May 27th. On July 16th of 2020, a CT scan of the abdomen demonstrated lymphadenopathy with a 2-centimeter renal mass. On July 24th of 2020, he was evaluated at the Mayo Clinic lymphoma clinic. He noted fatigue. His past medical history is significant for prostate cancer with no evidence of active disease with a low risk score. He has hyperlipidemia. His exam was unremarkable. His laboratory findings at the time we saw him revealed a hemoglobin of 12.2, the platelet count 115,000. The white blood cell count was 75,900 with an absolute neutrophil count of 5,310. Chemistry group was unremarkable. The LDH was elevated. May we see the radiology, please?
Good morning, Jason Young with radiology. I have a FDG PET-CT from July 29th of this year. And I'll just start from the top and come down here where we can see some anterior mediastinal lymph nodes that are prominent but not FDG avid at all. There's a small nodule on the periphery of the lung, not avid either, so probably no disease throughout the thorax. As we come down into the abdomen, we can see an enlarged lymph node here in the porta hepatis region. It does have uptake that's similar to blood pool, so not very avid. If we measure it here on the diagnostic CT, we can see that it's 2.7 by 2.0 centimeters, so it's clearly abnormal by size criteria. And then moving on to the spleen, we can see he clearly has splenomegaly 17 centimeters. And he also has a renal mass here that looks like it has solid components. Looking at that renal mass on the PET, it does have FDG uptake, so it looks like there's actual viable tissue there rather than like a blood products. So it looks like clearly a renal neoplasm. If we look over here onto the MIP, you can see there's focal uptake at the inferior margin of the spleen. That's SUV of 4. The lymph node was SUV at 2.5. So in summary, it looks like there is clearly abnormal spleen uptake and splenomegaly and enlarged upper abdominal lymph nodes, but not very avid.
So we have a bone marrow study, and I'll show you the flow cytometry on the bone marrow first. So you can see that we have a B cell population highlighted in red here that expresses CD19 and CD5. Also has relatively bright CD20, so brighter, more to the right here than we would usually see for like a CLL population. And then has sort of dim 23. You can see it's shifting for CD23 a little bit here and is kappa light chain restricted. If we go to the bone marrow, you can see that the core biopsy here is hypercellular for age. He's around 80 years old. And so this is about 70% cellular, I'd say. And even at low power, we can appreciate it's a little more purple than normal. So as we go to higher power, you appreciate just a lot of small kind of monotonous purple cells kind of streaming through here in the interstitium, not really forming discrete aggregates like lymphocytes sometimes do, but really just kind of filling out the interstitium here, corresponding with that B cell population we saw by flow. And if we go to immunohistochemistry, we don't have a CD20 because we kind of proved they were B cells by flow. But this is the cyclin D1. And I'll go to higher power here. You can see that cyclin D1 highlights most of these small lymphocytes with the nuclear staining. So that's consistent with mantle cell lymphoma. And that corresponds with the bright CD20 that we saw and the CD5 expression by flow cytometry. So one of our other markers for mantle cell lymphoma is newer, which is SOX11. And SOX11 is typically expressed in mantle cell lymphoma and not expressed in the other small B cell lymphomas, so can kind of help us in the differential diagnosis. This case actually is SOX11 negative, which is interesting because the leukemic subtype of mantle cell lymphoma, which isn't really an official WHO subtype, but is a sort of recently recognized biologic subtype, is frequently SOX11 negative, and that is the case here. The Ki67 in this case is relatively low. I'm not going to show the slide because it's a little bit difficult to look at because background hematopoiesis has a normally high Ki67, so you kind of have to subtract that out and extrapolate from where the cyclin D1 positive cells are, but it's fairly low. Interestingly, though, we were able to do a P53 mutation analysis on this case because it was a liquid specimen, as our clinicians know. Even though we frequently want this test on our mantle cell lymphomas, we don't currently have an assay we can do on paraffin. And this does have a TP53 mutation. So I will defer that discussion to later, but thank you.
Thank you.
Also, I should say this, the cytology here was small, not blastoid appearing.
So it was not blastoid appearing. I think that's interesting because
correct.
There was some earlier reports suggesting that. So the question is, and actually all three of these cases I'm going to make the decisions on today after tumor board, and I think it's a good precedent. So what's the treatment recommendation for this 82-year-old with the TP53 mutation? And I've listed potential options, which we'll come back to. I just want to frame this for a moment. As we had a case a couple years back, we reviewed this paper, but in non-nodal type mantle cell lymphoma is a specific biologic group, as Dr. King alluded to, and TP53 mutations were detected in high and low signature subsets back in 2012 in this particular paper. But a more interesting observation on TP53 mutations came out of the European group, and the interesting thing as a prognostic factor, I think this is probably one of the strongest prognostic factors biologically that we've seen in the last 5 years. In 183 patients, only TP53 mutations retained a prognostic impact for overall survival. The median overall survival was 1.8 years versus 12.7 years in unmutated cases, and 50% relapsed in 1 year. And this paper came out in 2017. And so there's different approaches we can take in the disease as things have evolved. Ibrutinib is active in about 2/3 of patients that were treated, and this was data that came out back in 2013, and this was further follow-up data in an abstract by Simon Rule in 2017. Reporting CR rates of 26.5% and PR rates of 43.2%. We don't have TP53 data on this. And then along came acalabrutinib, and the 12-month progression-free survival rate was 67%. And from a toxicity perspective, no atrial fibrillation, but bleeding was 23%. And I think one other potential way to think about this case is lenalidomide rituximab. Dr. Ruan, Memorial Sloan Kettering, initially reported this in 2017 and was published in a paper later in the New England Journal. and 61% of evaluable patients remained in remission. 11 progressed. And so we'll open this case up for discussion about potential approaches and recommendations. Dr. Inwards, you were, I think I saw you on. Yes.
Yeah. So up until you got to the point of telling us that he was P53 mutated, I was thinking this guy was in for an easy run. But that changes everything. And as best I can tell, and somebody tell me if they found something to tell you otherwise, we know what doesn't work very well in this disease, and that's standard therapy. What's less clear is what does work well in this fellow. So I would be inclined probably to not do Arbenda, or you're not going to transplant this guy. He's 82 and probably has another malignancy you need to deal with. So I would probably be looking at a BTK approach. You could consider a Rituxan Revlimid approach, though I don't know what the data really are for P53 mutated for either one of those approaches.
Do you have a feeling about, either ibrutinib or acalabrutinib first, and then secondly, where you'd put, I didn't have rituximab lenalidomide, I have the slide there we went through.
Yeah.
What would be your first choice?
To be honest with you, I like acalabrutinib a little bit better, just because I think, and there's not really good head-to-head data, but I think the risk of atrial and bleeding is probably a little less with acalabrutinib. But I don't know, and they've never really been compared head-to-head. You're looking at parallel series, so it's hard to know.
That's where I'm inclined to go. Do others have other thoughts and comments?
Hey, Dr. Haberman, this is Yu Chai. So I agree with you and Dr. Ingward. BTK inhibitor would be a very good choice. There are a few case reports in leukemic form of mantle cell lymphoma that were treated with BTK inhibitor off trial, and it seems like have good outcome. The other option would be we have this frontline pre-COP trial using venetoclax plus BR. So if we think venetoclax can kind of overcome the chemo resistance in patients with TP53 mutation, that might be something to consider, I guess. I had a gentleman with leukemic form of mantle cell lymphoma who initially was completely asymptomatic, but had a TP53 mutation and complex karyotype. We actually presented the case in tumor board approximately 1 year ago. Because he was completely asymptomatic, we initially observed him, but we couldn't do that for too long. His disease progressed relatively quickly with a high white count and symptomatic splenomegaly. I ended up putting him on the VEN plus BR trial, and he responded just after one cycle. Of course, we don't know how long that's going to be lasting.
By the way, one quirk of the literature on mantle cell lymphoma is a lot of times people use assessment criteria that are based on nodal disease and require measurable nodal disease. So a lot of these people that are non-nodal mantle cells aren't on the clinical trials. They're excluded. So for example, ACLY 308 that was looking at Arbenda, acalabrutinib versus Arbenda followed by maintenance. If you had a case like this, you're lucky in that because he's got that adenopathy in the upper abdomen, he would qualify. But if he just had lymphocytosis, marrow involvement, and splenomegaly, you can't go on the trial because you're not thought to be evaluable.
Yeah, the good thing about the pre-COP trial is it does take patients with leukemic form as long as they have a spleen that's 15 centimeters or above. This patient looks like a 17 centimeter.
And I'm glad to hear that because I tried to lobby the ACLY 308 people to say you're excluding a subset of mantle cell lymphoma patients. And oh, by the way, they tend to do well. You want them on your trial.
Steve here. Just wanted to ask, if this wasn't a P53 mutated patient, would you consider observation for the patient? And the reason for bringing that up is, if you look at the CLL literature, although P53 is a poor prognostic sign when patients are treated, there are a subset of patients, even with a P53 mutated, that when observed, still have a pretty reasonable outcome. So knowing that this guy's got a renal mass that needs to be taken care of, one option could be to delay a consideration for treatment for 3 months while you fix his kidney, and then come back and see what his mantle cell's done and whether the P53 really predicts a poor outcome when you don't need to give chemo. I mean, the issue with P53 is the inability to fix a cell that's damaged, but you have to damage it first. If you're not damaging it, then it probably doesn't matter.
No, it's an extremely good point. We are in the process of biopsying the kidney, and so there is a little bit further delay. Without the TP53 mutation, I would have just observed him and been very comfortable with that, actually.
Well, then I would have observed him now, whether he's P53 mutated or not.
Okay. Well, we're going to end up I need to make a decision eventually. He's going to need treatment. I think if you look at the course of his white count, this is a reasonably active process. But we're first biopsying the kidney, and then we'll need to make a decision, and then whether based on how rapidly he's progressing when we treat, then we'll need to consider either acalabrutinib or venetoclax BR.
Yeah. Dr. Haberman?
Yep.
Yeah.
I mean, I certainly agree with the ibrutinib or BTK inhibitor as first line, but just to add another line of therapy in your options, the RBAG 500 has some good data for elderly patients with mantle cell lymphoma. I don't think would be my first choice in this case, but there'll be something that is available and out there, and it's easier and better tolerated.
Oh, I appreciate that. Yeah, and I should have had that on the list actually, but thank you so much.